Also, yesterday, you remember accommodation? It was a function of lens also, right? So can you tell me which diameter of lens was changing during accommodation? Equatorial diameter, AP diameter, or equatorial diameter? Give me the answer in chat box. AP diameter, right? So AP diameter was changing during accommodation. And which curvature of the lens was changing? Anterior capsule or posterior capsule curvature was changing? Anterior capsule or posterior capsule was changing? Anterior, right? So there was no change in the posterior capsule, right? There was no change in the posterior capsule shape. Only the shape of anterior capsule was changing. Okay. Now, important question which is asked in your exam is, they will ask you what is the refractive index of nucleus and what is the refractive index of cortex. So write down refractive index of nucleus is 1.406. This is the highest refractive index in eye. Can you tell me what was the refractive index of cornea? Refractive index of cornea. You have to remember the number 1.376. And the refractive index of lens becomes important. And specifically in the lens, nucleus refractive index becomes important because this is the highest refractive index of eyeball. Okay. You have to remember the number. That is your 1.406 is the refractive index of nucleus of lens. Okay. Right. So also remember that this equator of the lens, the point where anterior capsule and the posterior capsule joins, this equator contains E cells. E cells. It contains E cells which undergo mitosis. Which undergo mitosis. They undergo mitosis. Okay. Next important point about lens, write down. Next important point in the lens, write down in the anatomy part. Lens is a transparent structure. It is transparent structure like which part of eyeball? Sclera or cornea? So cornea, right? I told you cornea is also a transparent structure. So lens is also transparent structure in eyeball, and it has functions, write down. It has functions of, first function is refraction of light. It takes part in refraction of light. And the power and the refractive power of lens is somewhere between 16 diopter to plus 19 diopter. And as I told you, the refractive power was 43 diopters. So out of 60 diopters, lens constitutes around 16 to 19 diopters of power. Right? Next important function, write down. After refraction, it also takes part in accommodation of lens. Accommodation. Right? So can you tell me for which vision accommodation is responsible? Accommodation comes into action for near vision or far vision? Near vision, right? So accommodation is also one of the function of lens. And you also know that lens is suspended by which structure? Lens is suspended in its position by suspensory ligaments. By suspensory ligaments, also called as zonules. Also called as zonules. Now talking about the blood supply, it has no blood supply. It has no blood supply like cornea. Cornea was also avascular. So this lens is also avascular and it has no nerve supply also. There is no nerve supply Clear? Now, one other important thing in the diagram, you have to know from clinical point of view, this is your anterior capsule, suppose. This is your posterior capsule. Important point is that this posterior capsule is more curved as compared to anterior capsule of lens. As compared to anterior capsule of lens. Now this center point of the posterior capsule is called as posterior pole. It is called as posterior pole, and this is thinnest part of the lens. This is the thinnest part of the lens. I will ask you a question when we will discuss cataract surgery, which is the thinnest part of the lens. The clinical importance of this posterior pole will lie during the cataract surgery. Okay, so posterior pole is the thinnest part of the lens. Okay, now can you tell me what is the definition of cataract? Cataract is any opacification of the lens or its capsule, be it anterior capsule, be it posterior capsule. So any opacification, because lens is normally transparent structure. So if there is any opacification in the lens, it will lead to cataract. Okay. So if there is opacification in the posterior capsule, the name of the cataract will be posterior capsular cataract, right? So depending on the location of the opacification, you will name the cataract. Okay. Now write down in the cataract. Write down in the cataract. Heading is cataract. Write down. Definition of cataract. It is any opacification in the lens or its capsule is called as cataract. First of all, we will discuss the main heading, acquired cataract. Acquired cataract. In the acquired cataract, first we will discuss senile cataract, right? Senile, as you all know, with aging, the cataract which occurs because of aging. So it occurs after more than 50 years of age. After 50 years of age. So this is senile cataract. Clear? Senile cataract. In senile cataract, first we will take on nuclear cataract. First we will take on nuclear cataracts. Okay. Now, as you know, this nucleus was located in the center part of the lens. It was located in the center part. This was a lens. So this was the location of your nucleus, right? So that is why these nuclear cataract, they are central cataract. They are central cataracts. So that is why they causes loss of vision in daylight. They causes more loss of vision during daylight. Why? Why? Because during daylight, your pupil is constricted or dilated. During daylight, your pupil is constricted, right? During sunlight, your pupil is constricted. So when the sun rays are coming through this miotic pupil, right? So these sun rays will be passed through the center only, right? And in the center, you have your cataract. So light rays will not be able to pass through the center. Okay. So that is why the patients who are having nuclear cataract, they will have more loss of vision in daylight. Okay. On the contrary, what will happen? On the contrary, what will happen during night time? Your pupil is big size. Pupil is comparatively dilated, right? So obviously, when pupil is dilated, the light rays can pass through the periphery of the pupil also, and right. So light rays can pass through the periphery, and the image can be formed on the retina. So patients who are having nuclear cataract, they will complain more loss of vision during daylight, and they will say that they are seeing better during the night hours. Okay, because pupil is dilated, so light rays can pass through the dilated pupil also. Okay, is it clear or not? Give me a thumbs up if it is clear. The concept is clear. Why there is more loss of vision in nuclear cataract during daylight? Okay, so because during daylight, what happens? During sunlight, the pupil is small size. Pupil is small size during daylight, right? Suppose pupil is small size like this. It is constricted. And behind the pupil in the center, nuclear cataract is present. Okay, so the sun rays which are passing, the light rays which are coming through the miotic pupil, they will be obstructed by the nuclear cataract which is centrally located, right? So light rays won't be able to focus on the retina. Ready when the pupil is dilated during night hours, there is pupil is midriatic during night, right? So light rays can pass through the periphery of the pupil also. And in the periphery, what is it there? In the periphery of the lens, there is cortex, right? It is a relatively clear area because cataract is present only in the center part. The periphery of the lens is clear. So definitely the light rays will be able to pass through this periphery and they will focus on the retina. So that is why these patients will have less problem or more vision during night hours, and during daylight they will have more difficulty in vision. Okay, clear? Okay. Now this and the patient complains of vision improving in dim light. Important question. During dim light, patient says that he is seeing better. Now write down. The pathology is that it starts from nuclear sclerosis. Important question. The pathology of nuclear cataract. The cataract formation starts from nuclear sclerosis. What do you mean by sclerosis? Sclerosis means hardening, right? That is why these nuclear cataracts are hard cataracts. Nuclear cataracts are hard cataracts, whereas cortical cataracts are soft cataracts. Okay? Nuclear cataracts are hard cataracts. These are, write down, hard cataracts. So because there is hardening of the nucleus, what will happen? Gradually and gradually, when the cataract increases, the refractive index of the lens will increase. Because of the hardening of the nucleus, the refractive index of the lens will increase. Okay. And when the refractive index of the lens increases as the patient ages and the cataract increases, it causes index myopia. It causes index myopia. Okay. Understood? Now try to understand one more concept here. Told that nuclear sclerosis is an example of senile cataract, right? So senile means after the age of 50 years. It starts after the age of 50 years. Okay. Now tell me at what age? RI means refractive index. So as I told you, the presbyopia starts at which age? Around which age presbyopia sets in? 40, right? So by the time this nuclear cataract starts, the patient is already presbyopic, right? So patient must be near glasses for reading newspapers, right? I'll tell you how the refractive index increases. Try to understand the concept here of the nuclear cataract. By the time the patient develops nuclear cataract, what will happen? The patient is already presbyopic. Okay? Because cataracts are at the age of 50 years and the presbyopia sets in after 40 years of age. So this patient must be using near glasses for reading newspapers. Okay? Now what happens? The patient, suppose, is 55 years of age and he develops nuclear cataract. Now, because nuclear cataracts are hard cataracts, okay, the pathology starts with the hardening of the nucleus. Whereas cortical cataracts are the soft cataracts. Cortex lies in the periphery, nucleus lies in the center of the nucleus. Nucleus lies in the center of the lens. Okay. So because there is hardening of the nucleus, what happens because of hardening, the refractive index increases. Okay. If hardening is not there, like in cortical cataracts, there is no effect on the refractive index of the cortex. But because there is hardening in the nucleus, the refractive index of the nucleus increases. Okay. Now, because the refractive index of the nucleus increases, what happens? It induces myopia. The refractive index increases and the patient develops index myopia. Okay. Index means refractive index increases, that develops myopia. Now tell me, in what happens in myopia? Patient is having difficulty in near vision or far vision. If the patient is myopic, if patient is myopic, what happens to the vision? Difficulty is there in far vision. Okay. The patient is able to read the near vision. Okay. He can read newspaper comfortably. Okay. Right. So what happens if the patient develops index myopia? So patient was using reading glasses, right? Patient was using reading glasses because patient was presbyopic. Now the patient develops index myopia, nuclear cataract. So what will happen? Patient now, because he develops nuclear cataract, he doesn't need any glasses to read the newspaper. Why? Because patient has developed index myopia. Okay. Now this change in the refractive index, because earlier the patient was using glasses for reading newspaper. Now, because of myopia, patient doesn't need any glasses to read the newspaper. This shift in the refractive index, this shift in the refractive status is known as second sight phenomenon. Important, write down. This shift is called as second sight phenomenon. Clear? This shift of refractive status of the is known as second sight phenomenon. Write down the definition of second sight phenomenon. The myopic shift in the patients enables elderly presbyopic patients to read near vision, that means clearly again without spectacles, right? So now this patient doesn't need, because of nuclear cataract, this patient doesn't need near vision glasses. Okay. Now, as I told you, there is hardening of the nucleus. They will ask you what is the color of the cataract. They will ask you what is the color of the cataract of this nuclear cataract. What is the color of the nuclear cataract? So write down appearance of nuclear cataract. It gives you yellow color. it gives you yellow color. And they will ask you why there is yellow color in this cataract. Write down, because of urochrome pigment. Because of urochrome pigment, it gives you a yellowish hue to the cataract. It gives yellowish hue to the nuclear cataract. It gives yellowish hue to the nuclear cataract. Clear? So remember, nuclear cataracts are hard cataracts, whereas the cortical cataracts are soft cataracts as compared to nuclear cataracts. Okay. Now write down the clinical features of nuclear cataract. Patient will complain to you of xanthopsia. Patient complains of xanthopsia. What is xanthopsia? Xanthopsia is yellow color vision. Because the color of the cataract is yellowish, so that is why a patient complains of yellow color vision. Yellow color vision. Okay? Because the color of the cataract is yellow. That is why the patient complains of yellow color vision. Suppose this is our refractive, this is our principal line, and this is our cornea, which is a transparent structure. This yellow part is cornea. And this is your lens. So in eyeball, these are the two transparent structures through which your refraction takes place. Okay. Now suppose this is a light object. This is your object. And somewhere here is your retina. Clear? Now what will happen? The light rays which are coming like this, parallel light rays, this is your air. So the refractive index of air, write down, is 1. Refractive index of air is 1. Okay. Now these parallel light rays which are coming like this, the first structure which comes in contact with this light is your cornea. It is your cornea. And as you know, the refractive index of cornea is 1.376, which is more than air, right? So there will be bending of light rays will take place. Okay. And these light will bend like this from the cornea. Behind the cornea, there is transparent structure which is called as anterior chamber, which contains aqueous humor, right? So the refractive index of lens is, this is your anterior capsule. Now again, the refraction will take place and the light rays will further bend like this. And somewhere here, the image formation will take place in the retina. Okay. Now because the refractive index of the nucleus, because of hardening, because it develops cataract, opacification, the refractive index of the nucleus increases. That is why, because of hardening, remember, hardening will induce myopia. It will induce myopia. The light rays will focus more in the front. Because of the hardening, the light rays will be focusing more in the front of the retina. As the hardening increases, the patient will develop myopia. Okay. So that is why the patient will not require reading glasses, which earlier the patient was requiring for reading newspapers. Clear? Now, second example of cataract, second heading, write down. Second heading after nuclear cataract, we will take on cortical cataract. Cortical cataract, as you all know, this was our lens. This is your cortex, this is your nucleus, and this is your location of the cortical cataract. So as you know, these cortical cataracts are the peripheral cataracts. So write down, the location of this cataract is peripheral. These are peripheral cataracts. So that is why they causes more loss of vision in dim light. They cause more loss of vision in dim light. Okay. Why they cause more loss of vision in dim light? Because in dim light, the pupil is dilated. Okay. Pupil is dilated. Bigger size pupil. Now, when light rays are coming from the object, right? So when they pass through the periphery of the lens, the cataract is present. So they will hamper the image formation in the periphery. Whereas during daytime, when the pupil is constricted, the light rays will be forced to pass through the center of the lens. Okay, periphery, the light rays will not pass, and the periphery cataract is present. So these cortical cataract patients, they will see better during daytime, and during night time, because pupil is dilated, so light rays will be passing through the periphery where the cataract is present. So patient will have problem in night vision. Okay, so write down these cortical cataract patients, they will have more loss of vision in dim light, and vision improves in daytime. Vision improves in daytime. Okay. Now write down the pathology of cortical cataract. Pathology of cortical cataract. So as we know that these cortical cataracts are soft cataract. These are soft cataract. So the pathology starts with hydration. There is hydration of the nucleus. There is hydration and coagulation of lens proteins. There is hydration and coagulation of lens proteins, which leads to formation of vacuoles and water cleft, which is the earliest sign of cortical cataract. Now, what does it mean? Formation of vacuoles and water cleft. Again, see the diagram. This is your lens. So there is formation of vacuoles. How the vacuoles look like? They look like this. Vacuoles are seen in the periphery of the lens. They are seen in the periphery of the lens because cortical cataract is present in the periphery. Because it is present in the periphery, that is why the location of water cleft is also periphery. So as the location of this cataract is in the periphery, see, this is the action is present in the periphery, whereas the center is comparatively clear. Center is comparatively, this is nucleus, right? So nucleus is comparatively clear, whereas where is the periphery, like this, right? So this is an example of your cortical cataract, and these cortical cataracts are soft cataract, whereas the nuclear cataracts are hard cataracts. Is it clear from the picture, the location of the cortical cataract? Yes or no in the chat box? Okay, so this is a perfect example of the cortical cataract. Now write down pathology of cortical cataracts. Pathology of cortical cataracts, write down. Starts with hydration and leads to formation of vacuoles. And after this formation of vacuoles, what will happen? Write down. It will lead to a stage which is called as immature senile cataract. Now, suppose there is a stage of immature senile cataract. Patient has immature cataract, but still the patient is not getting operated. And the hydration will continue, right? As the patient ages, suppose cataract starts at the age of 50, patient doesn't get operated at the age of 60 also, but there is continuation, hydration is there, right? So what will happen if there is maturity is happening in the nucleus? This immature senile cataract, one day it will convert into a mature senile cataract. Complete opacification will be there of the lens. Okay. This color of mature senile cataract, write down, it is pearly white color. The cataract color is in mature senile cataract. The color of mature senile cataract is pearly white color. Okay. It is pearly white in color. Now try to understand one concept here. Now suppose this is my cornea, right? This is my cornea. This is my iris. Okay, this is my iris and this is my cornea. Behind the iris, which structure is present? Tell me in the chat box. Behind the iris, which structure is present? Biconvex structure behind the iris. Which structure is present? This is my cornea. This is behind the cornea. There is anterior chamber, and this is my iris, right? So behind the iris, posterior chamber is present. Okay, it is lying between the lens, right? So behind the iris, lens is present, right? And between the iris and the lens, PC is present. Okay, good. So now try to understand one concept. Suppose the patient is not getting operated and he has developed mature senile cataract. Okay, so there is continued hydration is there, right? Continued hydration is there. So what will happen? This lens which is present behind the iris, it will increase in the diameter. Okay, so AP diameter of the lens will keep on increasing if the patient doesn't get operated. So what will happen to the anterior chamber depth? Can you tell me if the lens behind the iris is keep on increasing in size, if patient is not getting operated, what will happen to the anterior chamber depth? It will become shallow or it will become deep? It will become shallow. So AC depth, anterior chamber depth will become shallow. It will not become deep. See, this is the anterior chamber, right? Behind the iris, lens is swelling up. It is swelling up. So it will push the iris forward now. So that is why the AC depth will become shallow. AC will become shallow and not deep. The concept is clear. AC will become shallow, not deep. If the lens is continuously hydrating, it is swelling up because of continuous hydration, right? Yes, bulge. So bulging of the lens will be there. So definitely when bulging is there, iris will be pushed forward. Iris will be pushed forward towards the cornea, right? So anterior chamber depth will become shallow and it will not become deep. Is it clear? AC is becoming shallow? Yes or no? In the chat box, write down, please. The concept is clear? Why AC is becoming shallow? Yes. Okay. Now one more concept, try to understand. See, which important structure is present between the cornea and the iris? This is PC is not. The PC is there will be no change. PC will be there, right? Posterior chamber will be there and aqueous humor will be as it is. Okay. Anterior chamber is important. You have to focus on anterior chamber. AC will become shallow. Why as anterior chamber is important? Try to understand this thing. See, in between the iris and the periphery of the cornea, this is the junction, this one. Can you see this structure? This one. At the junction of the periphery of the cornea, endothelium, right? Backside of the cornea is endothelium, right? So at the junction of this endothelium and the iris, this part is called as angle of the anterior chamber. This part is called as angle of the anterior chamber. And this angle of the anterior chamber contains very important structure which is called as trabecular meshwork. It contains trabecular meshwork, right? So what is the importance of trabecular meshwork? It helps in outflow of the aqueous humor, right? So this is the side where aqueous humor leaves your eyeball. This is the side where your aqueous humor, which is continuously producing from your ciliary body, it exits your eyeball through this trabecular meshwork. Understood this much? Yes, sir. Give me a thumbs up if the concept is clear to you. Yeah, I'll show you the images also. So, can you understand? Just tell me what. Can you understand me? Can you tell me what is the location of trabecular meshwork? It is present between the iris and your back of the cornea, right? In the periphery of the angle of anterior chamber. I'll show you one picture, right? See, this is the picture. Suppose this is your angle. This is the back of the cornea, right? This is the back endothelium, and this is your iris. This is your iris. Can you see this angle in the periphery? This part, right? So this is the location of angle of anterior chamber. This is the location of angle. And this angle of anterior chamber, this one, this contains a structure which is called as TM, trabecular meshwork. Okay. So when this lens thickness increases, the lens when bulges, what will happen? This will push the iris forward, right? This will push the iris forward, and the anterior chamber depth, the anterior chamber will become shallow. Clear? Screen is lagging. Is it clear now? Is it clear now? Okay. So when the lens thickness increases, I was telling you trabecular meshwork location, right? So trabecular meshwork is present between the angle of the anterior chamber. Now, what is the location of anterior chamber angle? It is present in between the iris and your back of the cornea. This is the angle of anterior chamber. This is your angle of anterior chamber. This one, right? It is present between iris and the back of the cornea. This red part is your angle of the anterior chamber. This angle of the anterior chamber contains trabecular meshwork, TM. Okay. Now, this is the side where your aqueous humor leaves your eyeball, right? This is the anterior chamber, and this contains aqueous humor, right? So this is the side where from the aqueous humor, it will leave your eyeball through the trabecular meshwork. Through the trabecular meshwork, your aqueous humor will leave your eyeball. Okay. But when the cataract, the density of the cataract increases, the lens bulges. So when the lens bulges, what will happen? The iris is pushed towards your cornea. Iris is pushed towards the cornea, and the anterior chamber will become shallow. Anterior chamber will become shallow. This will become shallow. It will narrow down, right? So what will happen? Obviously, then when the anterior chamber becomes shallow, the trabecular meshwork, it will block. There will be blockage of the trabecular meshwork. And if there is blockage of the trabecular meshwork in this part, what will happen? the aqueous humor will not be able to pass through the aqueous humor will not be able to pass through this structure, which is trabecular meshwork. So what will happen if there is obstruction in the outflow of the aqueous humor through the trabecular meshwork? What will happen? The intraocular pressure inside the eyeball will increase. The IOP will increase. Intraocular pressure will increase. Understood this much? Clear? Because AC depth is shallow, it will compress your trabecular meshwork. The trabecular meshwork will block. Okay. And the aqueous humor will not be able to pass from the eyeball. Okay. So aqueous humor, because exit is not possible, what will happen? It will exert pressure inside the eyeball, and the intraocular pressure, it will increase. Right? Now write down. Next important point. Because the mature senile cataract swells up again, if the patient doesn't get operated, it will lead to intumescent cataract. It will lead to intumescent cataract. What do you mean by intumescent cataract? Swollen lens. Swollen lens is called as intumescent cataract. Now, because this intumescent cataract will lead to shallow anterior chamber. Shallow anterior chamber, and it causes secondary angle closure glaucoma. It will lead to secondary angle closure glaucoma. Because it is secondary, because it is occurring because of cataract. That is why we have coined the term as secondary angle closure glaucoma, right? So this type of secondary angle closure glaucoma, which is occurring because of cataract, swollen lens, this type of secondary angle closure glaucoma is called as phacomorphic glaucoma. Important question. This is important question. Phacomorphic glaucoma. Clear? So cataract inducing glaucoma, right? That is why we have coined the term as secondary angle closure glaucoma, because mature cataract, which is intumescent, swollen lens, that is inducing your glaucoma. That is why we are calling it as secondary angle closure glaucoma. Understood why the angle are closing? Because the lens is pushing the iris forward, and between the iris and the cornea, your trabecular meshwork is present, right? So that trabecular meshwork gets blocked when iris is pushed forward, right? Because this trabecular meshwork is blocked, there is no site for aqueous humor to pass through, right? So this aqueous humor will exert pressure inside the eyeball, and IOP will increase. And when IOP increases, it leads to glaucoma, right? So that glaucoma is called as secondary angle closure glaucoma. Clear? Is it clear? Yes or no? This concept is clear? Okay. Good. Next type of cataract, write down. Next type of cataract, write down. The name is posterior subcapsular cataract. Posterior subcapsular cataract. Now suppose this is your biconvex lens. Suppose the opacification develops just in front of the posterior capsule. If the opacification develops just in front of the posterior capsule, this is posterior capsule, this is anterior capsule. Now the name of this cataract which is occurring just in front of the posterior capsule, it is called as posterior subcapsular cataract. It is called as posterior subcapsular cataract. So this cataract lies in front of posterior capsule, right? This short form is PSC, posterior subcapsular cataract. The short form is PSC. Yes, is it? These are all part of senile cataracts. These are all examples of senile cataracts. Now, important question, write down. This posterior subcapsular cataract causes maximum loss of vision. It causes maximum loss of vision. If they ask you which type of cataract causes maximum loss of vision, answer will be posterior subcapsular cataract. Answer will be posterior subcapsular cataract. It causes maximum loss of vision. Write down the why it causes maximum loss of vision. Due to its location at the nodal point of eyeball. At the nodal point of eye. Now, what is the location of nodal point? Again, try to understand the concept here. This is your principal axis. This is your cornea. This is your biconvex lens. Here is your retina. This is your retina, right? Now, because this cataract is lying at the principal axis just in front of the posterior capsule, right? So that is why the image is not focusing on the retina, right? Behind the retina. So this is just lying in front of the retina. And here is your nodal point of the eyeball. This is your nodal point. Just behind the posterior capsule of the lens, there is location of the nodal point. So this cataract is lying just in front of the posterior capsule or nodal point of the eyeball. That is why this cataract causes maximum loss of vision, because it is lying in front of nodal point, and this nodal point is coinciding with the retina. Clear? So both in day or night, it causes maximum loss of vision. PSC causes maximum loss of vision. Clear? Now, what else is important in PSC? Write down. They will ask you what are the causes of posterior subcapsular cataract. Write down the important causes of posterior subcapsular cataract. Patients who are on steroids, they develop posterior subcapsular cataract. Patients who are exposed to radiations like X-rays, they also tend to develop posterior subcapsular cataract. Patients with myotonic dystrophy, patients who get trauma, they are also prone to develop PSC. And pregnancy. So these are the important causes of posterior subcapsular cataract. These all the causes you have to remember. These are important questions, right? Next important cataract is, next heading, write down, anterior subcapsular cataract. Now, as the name suggests, you all know what is the location of this cataract. Anterior subcapsular means the cataract is lying just in front of the anterior capsule. Just beneath the anterior capsule of the lens. So the name is anterior subcapsular cataract. Important cause, write down. You just need to remember the causes of anterior subcapsular cataract. The important one is atopic dermatitis. Second cause is amiodarone. Third cause is acute angle closure glaucoma. And the last cause is chlorpromazine, can also cause anterior subcapsular cataract. So these are the examples of your senile cataracts. These are the examples of your senile cataracts. Now coming to the next category of cataract, write down the main heading. We will discuss metabolic cataracts. Metabolic cataract means the cataract which is occurring due to some metabolic disorders in your body. And the most important one is diabetes mellitus. Diabetes mellitus. In diabetes, it is snowflake cataract. It is an example of cortical cataract. It is example of cortical cataract, right? So the image which I showed you, that was example of diabetes cataract, which is a type of cortical cataract, which was example of cortical cataract. This one. So this is a typical example of snowflake cataract, and it is example of cortical cataract. Okay. So cortex, as I told you, it lies in the periphery and it is a soft cataract as compared to nuclear cataract. So very important question. They will ask you directly, cataract which is associated with diabetes. Example is snowflake cataract. Next important disorder, write down. After diabetes, second important metabolic disorder is galactosemia. Galactosemia. This galactosemia is associated with oil droplet cataract. Oil droplet cataract, which is an example of, which is a type of posterior subcapsular cataract. It is an example of posterior subcapsular cataract. Now, reflex. In which disease or disorder we have studied oil droplet reflex? Yesterday we discussed oil droplet reflex, and I gave you mnemonic also. Oil droplet reflex, keratoconus. What was the mnemonic? Cones. Cones, right? Yes, correct. So oil droplet cataract is seen in galactosemia. Okay. Now write down. Important question. Exclusion of, in galactosemia only write down, exclusion of galactose may reverse the lenticular changes, may reverse lenticular changes. So if you exclude the galactose in the diet, it can reverse the cataract changes. So that is why important question is that this is the only reversible cataract. This is the only reversible cataract. And next important question is that this is diagnosed by presence of reducing sugars in urine. This is diagnosed by presence of reducing sugars in urine. So 3 important points in galactosemia. It causes oil droplet cataract. It is the only reversible cataract, and it is diagnosed by reducing sugar in urine. Third metabolic disorder, write down. Wilson's disease. Wilson's disease. It characteristically causes cataract, which is name is sunflower cataract. You will see a Wilson's disease. Clear. Also, the finding which you see, another finding which you see in Wilson's disease is in the cornea, you see KF ring. You see KF ring. I'll show the image. So this is the Christmas cataract we will discuss later on. See, this is the picture of KF ring. Can you appreciate a yellowish deposition is there in the periphery of the cornea? This one. This, and it is typical finding seen in Wilson's disease. The color of this ring is golden brown in color. This is golden brown in color, right? So typically seen in Wilson's disease, and this is an image-based question which can be directly asked regarding Wilson's disease. So write down. It causes sunflower cataract. It also presents with Kaiser-Fleischer ring. Short form is KF ring. The color also you have to remember, the color is golden brown. This is golden brown color of, so there is copper deposition in the cornea. They will ask you in which layer of cornea there is deposition of copper. Then answer will be in Descemet's membrane at the periphery of the cornea. This is not seen in the center of the cornea. This is seen in the periphery of the cornea. And which layer of cornea is involved? Descemet's membrane. Clear? This much is clear. Give me a thumbs up. Yes, copper deposition is there. Cuprous oxides ions are deposited in the Descemet's membrane of the cornea. Wilson's disease is clear? Okay, next. Next metabolic disorder, write down. Fourth one is myotonic dystrophy. Myotonic dystrophy. So the cataract which is associated with myotonic dystrophy, the name is Christmas tree cataract. Christmas tree cataract. It is a type of posterior subcapsular cataract. Posterior subcapsular cataract. These are the 4 examples of metabolic cataracts. Metabolic cataracts. Now, next heading, write down. Next heading is traumatic cataracts. Cataract which is associated with trauma. So first, most common trauma which we see in the OPDs is your blunt trauma. Blunt trauma means trauma which can occur due to a fist injury also, right? So that leads to blunt trauma and it can also cause cataract. So the cataract which is associated with blunt trauma, write down, name is rosette-shaped cataract. Rosette-shaped cataract. Important question. Let's see the image also. See, this is a typical example of rosette-shaped cataract. They can also ask you an image-based question. This is the example of rosette-shaped cataract. Remember, this is seen because of blunt trauma and not penetrating trauma. So there is difference in blunt trauma and penetrating trauma, right? So the trauma which is occurring due to fist injury is your blunt trauma, and trauma which is occurring because of this pen. If pen is hitting my eye, this will lead to penetrating trauma, right? So this blunt trauma will give you rosette cataract and not the penetrating trauma. Okay. So very important question. commonly asked in your exam about rosette shaped cataract. Clear? This is an example of posterior subcapsular cataract. Posterior subcapsular cataract, which is also a central cataract, and it causes maximum loss of vision, right? Maximum visual disability because it is located at the nodal point of your eyeball. Clear? Okay, next, write down. Next, after blunt trauma, the trauma can also occur because of infrared light, infrared rays. These infrared rays can give you which type of cataract? Write down name, glass blower cataract. Glass blower cataract occurs because of infrared light rays. So out of these two, blunt trauma is very, very important, and you cannot afford to miss rosette shaped cataract. So these are the examples of traumatic cataract, right? Next heading is complicated cataract. Write down. What is complicated cataract? Write down the cause of complicated cataract. So these cataracts occur due to disturbances of lens nutrition. They occur due to disturbances of lens nutrition, right? What is the appearance of these cataracts? They give you a breadcrumb appearance. They give you bread with polychromatic luster. Important question. What is the appearance of posterior these complicated cataract? Answer is breadcrumb appearance with polychromatic luster. Now, next important question is, what are the examples of complicated cataract? To remember the examples of complicated cataract, the mnemonic is Ramu Kaka. You have heard of Ramu Kaka in Bollywood, right? So the mnemonic is Ramu. You have to remember Ramu in complicated cataract. This will make your life easy in exam, where R stands for retinitis pigmentosa. R stands for retinitis pigmentosa. A for angle closure glaucoma. Angle closure glaucoma. M stands for myopia, which is high myopia. What is high myopia? We will discuss in optics. And U stands for uveitis. U stands for uveitis. If they ask you which is the most common cause of complicated cataract, then answer will be uveitis. Then answer will be uveitis. Clear? Now, next point, write down. After the classification of senile cataract, as you all know, there is no medical treatment for cataract, and surgical treatment is mainstay. Surgical treatment is your mainstay, right? Now, techniques are there. Write down the surgical techniques which we do in our day-to-day life in ophthalmology. So first surgical technique, the name is ICCE. The full form is intracapsular cataract extraction. intracapsular cataract. So this surgery is obsolete in 60s, 70s. Nowadays, we are not doing this surgery, right? So the lens in this surgery, what we were doing is, write down, lens is removed completely along with the capsules, along with the capsule completely. So this surgery we are not doing nowadays. Suppose this is our lens and the patient has cataract here. Some nuclear cataract is also there and some part of cortical cataract is also there. Try to understand the concept, right? So we are going to operate this patient and we are going to remove the cataract, right? We are going to remove the whole of this cataract and we will implant. What we will implant when we remove the lens? What we will implant? If you are removing the lens, then obviously we will have to implant an artificial intraocular lens like this. Artificial intraocular lens inside the bag, right? So how the artificial lenses looks like after the surgery? What we insert. So this is the picture of cortical cataract. Can you see the vertical water clefts are there in the periphery? These are the examples of peripheral cataracts and these are cortical cataracts, soft cataracts, right? This is the picture of Christmas tree cataract. Christmas tree cataract seen in myotonic dystrophy. Christmas tree cataract. See, this is the example of artificial IOLs which are coming in the market. Different shapes are present. And we are, after removing the cataract, we implant these intraocular lenses inside the eyeball, right? So this is the part of optic. This artificial IOL has two parts. This part is optic and this is your haptic. This is your haptic. So what we do during cataract surgery, this is your convex lens and this is your cataract, suppose. So after removing this cataract, whole lens we eat up, right? With the machine, we eat this cataract lens, right? And after eating the opacified cataract, we implant artificial IOL inside the lens, right? This much is clear? Yes or no? After removing the cataract, we implant artificial IOL, which is intraocular lens inside the lens. Clear? Now, what we do during cataract surgery, what we do with the help of some instruments, what we do, we will make, this is your biconvex lens, suppose, this is your cataract. What we will do during cataract surgery, we will make a small opening here. We will make a small opening in this capsule. Which is this capsule? Anterior capsule. This is your anterior capsule and this is your posterior capsule, right? So with the help of a needle or instrument, we will make a small opening here in the anterior capsule. This process of making a small opening in the anterior capsule is called as capsulotomy. This is called as capsulotomy because we are cutting the capsule, right? Which capsule we are cutting? Anterior capsule or posterior capsule? We are only cutting anterior capsule. We are not touching posterior capsule. Okay? Understood this much? Yes or no? We have to make opening in the lens and we are only cutting the anterior capsule. Posterior capsule we are not touching. Okay. So this process or this step of making an opening in the anterior capsule is called as anterior capsulotomy. This is called as anterior capsulotomy. Now, after entering into this lens, after making an opening, what will happen? We will eat whole of the cataract lens. We will eat this whole lens and we will not touch this posterior capsule. We will not touch this posterior capsule. And after eating this whole lens, what we will do? We will implant an artificial IOL. We will implant an artificial intraocular lens inside this lens. We will implant an artificial IOL, intraocular lens, inside this biconvex lens. So which structure we have not touched yet? We have not touched your posterior capsule. Okay. So what is the location of IOL implantation? It is lying in front of the posterior capsule and behind the remnant of anterior capsule. Some part of the anterior capsule we have cut because we have to remove the cataract lens. So that is why we have to make an opening also. Clear? This much is clear what we are doing during cataract surgery? Clear or not? Give me a thumbs up if it is clear. Okay. Now suppose when I'm doing a surgery, and my instrument, suppose it touches your posterior capsule. By accident, suppose my instrument touches my posterior capsule. So as I have told you, the posterior capsule is thinner as compared to anterior capsule, right? Remember in the anatomy, I told you anterior capsule is 3 times thicker than the posterior capsule. So this posterior capsule is very thin structure. And by accident, suppose due to any accident, my instrument touches my posterior capsule. What will happen if this posterior capsule gets ruptured? What will happen if this posterior capsule gets ruptured? Which liquid is present behind the posterior capsule of lens? Can you tell me which liquid is present behind the posterior capsule of lens? Vitreous humor, right? This is vitreous humor now. Behind the posterior capsule, vitreous humor is present, right? So what will happen then if it ruptures? Vitreous humor will enter inside the anterior segment of my eyeball, right? You remember what was the location of anterior segment? All the structures which are present in front of posterior capsule of lens comprises your anterior segment. So vitreous humor will automatically come inside the anterior segment, inside the lens. So then I will have to cut that vitreous also. So that is a complication. That is a very commonly done complication during the cataract surgery. That complication is called as posterior capsular rupture. That complication is called as posterior capsular rupture. Now, try to understand another concept also. Will AC be left open? No, AC is not left open. It will heal on its own and it will be closed on its own. No need to put suture. We make biplanar incisions and the incisions are self-sealing and it will heal on its own. Try to understand another concept. Now, suppose a complication has occurred and my posterior capsule gets ruptured. This is my posterior capsule. It gets ruptured. And I know, and I am in the OT. And can you tell me where will I put the intraocular lens now? I have done anterior capsulotomy also. And by accident, I have ruptured the posterior capsule. Now, can you tell me where will I implant the intraocular lens? If I implant the intraocular lens here, what will happen if the PC is rupturing? this intraocular lens can fall back in the vitreous cavity, right? This intraocular lens, because of gravity, it will fall back in the vitreous cavity in the posterior segment of eyeball, and it will be a big complication. It is very difficult to manage for the surgeon if the lens drops in the posterior segment. Okay, understood this much? Can you do you understand the problem which I am telling you? If the PC get rupture, the intraocular lens can fall back in the posterior segment, and then it will become a very complicated case. Okay, so can you tell me now what options do I have if the PC get rupture? Where will I implant the intraocular lens? Again, try to understand. Suppose this is my cornea. This is my cornea. This was lens, anterior capsule. I have done anterior capsulotomy. And some part of PC, posterior capsule, gets rupture. Can you tell me what are the other options I am left with? This is my iris. This is my iris. This is my iris. So I can implant my intraocular lens behind the iris and in front of the anterior capsule of the lens in the posterior chamber. This part is called as PC, right? Behind the iris and the remnant of anterior capsule, I can implant the intraocular lens. Clear? Next other possibility is that I can implant the intraocular lens in the anterior chamber also. Anterior chamber also. The haptic will be lying on the iris and the optic will be lying here in the pupil. Understood? This much is clear? What two options I have if the PC get rupture? So my first priority will be that I implant the intraocular lens here if the PC is intact. So this is my top priority. If by chance my PC gets rupture, the other two options do I have? What I have is that I implant the intraocular lens behind the iris and in front of anterior capsule of the lens, or I can also implant the lens in the anterior chamber. Clear? So these are the three locations for implantation of IOL. Clear? This much is clear? Yes or no? Give me a thumbs up if it is clear. The three locations of IOL implantations. Okay. Great. Now write down the surgeries ICC we have discussed. So those were the time when we used to remove the lens completely and we were keeping the patient aphakic. We were keeping the patient aphakia. Aphakia means no intraocular lens, no IOL. So we were removing the whole of the lens and we were not implanting any intraocular lens. So this surgery is obsolete nowadays, right? So now what we are doing right now, the second surgery is ECCE. The full form is extracapsular cataract extraction. Extracapsular cataract extraction. What we are doing now, write down, in ECC, lens is removed completely. Sorry. What we are doing in ECC, write down. Just clean it. So the lens fibers, write down, lens fibers, nucleus plus cortex, both. Nucleus plus cortex, lens fibers are removed in ECC along with anterior capsulotomy. followed by IOL, intraocular lens implantation, followed by IOL implantation. Now this ECCE has three techniques. ECCE has three techniques. The name of first technique is called as conventional ECCE. Second surgery is small incision cataract surgery, SICS. SICS is small incision cataract surgery. Third surgery is phacoemulsification. Phacoemulsification is the most commonly done surgery nowadays. So in private sector, private clinics and hospitals, the most commonly performed surgery is phacoemulsification. Whereas in SICS, in the camp surgeries where we are doing bulk surgeries, 50 cases per day, 100 cases per day, the more commonly done surgery is SICS. Okay. ECC also we are not doing nowadays very frequently. So the most commonly done is SICS and phacoemulsification. And if they ask you most commonly done surgery is phacoemulsification. Clear? Now, what is the difference between SICS and phaco? Write down. Draw these two lines and write site of incision and the size of incision. SICS and phacoemulsification. The short form is phaco. Phacoemulsification. So site of incision in SICS, where we are applying incision in SICS, we are giving the incision on the sclera. We are giving the incision on SICS. And the size of incision is around, incision is 5 to 7 millimeter long. The incision is corneal. It is clear corneal. And the size of incision is 2.2 to 3.2 millimeters. 2.2 to 3.2 millimeters. Nowadays, we are doing phaco in 1.9 size of incision also. So as you are seeing, as we have shifted from SICS to phaco, the size of the incision is decreasing, right? So when the size of the incision in surgery decreases, the chances of post-op complications also decreases, right? And the post-operative recovery is also early as compared to SICS in phaco. So that is why this phaco is more commonly done nowadays as compared to SICS. Okay, so you have to remember the size also and the site of incision in SICS and phacoemulsification. Clear? Right. So now suppose a patient is having cataract and how will we give incision on sclera? So we remove the conjunctiva first of all. Above the sclera, what is present is your bulbar conjunctiva is present, right? So we have to cut the conjunctiva, and with the help of 15 number blade, we give incision on the sclera. Okay. We cut the conjunctiva, and then with the help of 15 number blade, we make an incision on the sclera. Whereas in phaco, directly the blade is entered in the cornea. No, conjunctiva is not removed. We do the cautery. We do the cautery on the conjunctiva. It is attached again. Right? Now, suppose a patient is having, there is no need to grow the conjunctiva. what we have reposited the conjunctiva, we do the cautery again, and the cautery conjunctiva is attached. We make a cut in the conjunctiva, we slightly remove the conjunctiva, and we make a incision on the sclera. After the surgery, that conjunctiva is reposited again with the help of cautery. Okay, yeah. So suppose a patient is having cataract and we are planning the cataract surgery of that patient, right? So we have decided that we are going to do phacoemulsification in that patient. So because the curvature of corneal curvature in each and every individual is different, right? So the intraocular lens which you are going to implant, that the power of that intraocular lens in every individual is different. So there is a formula by which we calculate the power of the intraocular lens which we are going to implant in that patient, right? So you need to remember what is the formula for IOL power calculation. So write down next heading, calculation of IOL power. Calculation of IOL power. Write down step 1. Step 1 is you measure corneal curvature in patient. Now you have to tell me what is the name of the technique by which you measure the corneal curvature. What is the name of the technique by which you measure the corneal curvature? Right. It is called as keratometry. Very good. So we have to go for keratometry. Pachymetry is you have to measure corneal thickness. You measure corneal thickness by the pachymetry, right? And not the curvature. So you first measure the corneal curvature. Then step 2, you measure the axial length of the eyeball. You measure the axial length of the eyeball. Now, what is axial length? Suppose this is our eyeball. This is our cornea. This is your whole eyeball, suppose. Right? This is your optic nerve, which is going to brain, iris, what is axial length of eyeball? Try to understand. The distance from the tip of the cornea till your optic nerve head. This distance is called as axial length of eyeball. This is in normal individuals, it is 24 millimeters. It is 24 millimeters, right? So in every individual has different axial length, right? So that is why every individual will have different power of intraocular lens. So in each and every individual, you have to measure the axial length of the patient, right? So by which instrument we measure the axial length of the patient? The name of the instrument is called as A scan. It is called as A scan. With the help of A scan, we measure the axial length of the patient. Normal axial length in normal individual is 24 millimeters, right? Another important point here regarding axial length, this is normal. If the patient is having axial length more than 24 millimeter, means if the size of the eyeball is larger, right, then the patient is myopic. Then the patient is having myopia. Patient is myopic. And if the patient is having axial length less than 24 millimeter, means short eyeball. Those patients who have short eyeball or short axial length, those patients are hypermetropic. Those patients are hypermetropic. Okay. So the name hypermetropia is lengthier than myopia, but the axial length is shorter as compared to myopic eyeball. This is This is clear to you? If the axial length is more than 24, patient is myopic. If the larger eyeball, the patients are myopic. Shorter eyeball, short length, then the patient is hypermetropic. Clear? Yes or no? Okay. So coming back to the measurement of axial length is the distance or the length, distance from the tip of the cornea. This is cornea. Distance from the tip of the cornea till your optic nerve head, optic disc. That distance is called as axial length of eyeball. That is called as axial length of eyeball, and normal axial length is 24 millimeters. Yes. So coming back to the calculation of IOL power, so two steps. First, we do keratometry. Second, we measure the axial length, right? So after doing these two steps, step 3, write down. We put these two values in a formula, that the name of this formula is SRK2 formula. So name you have to remember. These two values after calculation, the keratometry values and the axial length values, these two values are put in a formula that is called as SRK. Shah Rukh Khan, this is not Shah Rukh Khan, this is SRK2 formula, which is used to calculate the IOL power. This is the most commonly used formula, right? So after putting these values in SRK2 formula, you will get a value that is your IOL power. That is your IOL power values. Okay. Now next heading, write down. Next heading is IOL, intraocular lenses. Intraocular lens. Intraocular lens. So you remember what were the 3 locations of intraocular lenses? What were the 3 options which we discussed for implantation of IOL? We will discuss again. Write down. IOL may be implanted. IOL may be implanted as, now you all of you draw this diagram. Draw this diagram. This is your cornea, anterior chamber. This is your posterior chamber. This is your posterior capsule. Posterior capsule. Clear? Draw this diagram. So what are the 3 locations in which we can implant intraocular lens? So first location is this one, anterior chamber. Second location is in the posterior chamber, behind the iris and in front of anterior capsule of lens. This is your anterior capsule of lens. Why I have not drawn the anterior capsule fully? Because we have done anterior capsulotomy during the operation, right? So this is the second option. And the third option is in the bag. See, this third location in front of posterior capsule and behind the anterior capsule, this third location is commonly called as in the bag. This is the bag of the lens, right? Okay, so these are the 3 locations. So write down now, IOL may be implanted as number 1 location is anterior chamber intraocular lens, commonly called as ACIOL. ACIOL is anterior chamber intraocular lens. Number 2 location, write down, it is in the ciliary sulcus. It is in the ciliary sulcus, behind the iris and in front of the lens. in the posterior chamber. Third location is called as in the bag. In the bag. So these two locations are in the posterior chamber. 2 and 3 are in the posterior chamber, whereas 1 is in the anterior chamber. If they ask you in the question, write down which is the best site for IOL implantation, then answer will be in the bag. Answer will be in the bag. Clear? So these are the three options of putting of the IOL in the cataract patients. Number 3 location in the bag is your favorite best site for IOL implantation. Now, next heading, write down in the IOL only. It can be of two types. AC IOL, which is anterior chamber intraocular lens. This AC IOL is made up of which material? The name of the material is PMMA. The full form is polymethylene meth acrylate. So this is important question. They will ask you what is the material of ACIOL. ACIOL is made up of PMMA. Important question. Next is after ACIOL, we have discussed PCIOL, posterior chamber IOL. They can be of two types. They can be rigid PCIOL or they can be foldable IOLs. Nowadays, with what we are putting in paid cases, we are putting foldable intraocular lenses, right? In the CAM surgeries, we are putting rigid lenses which are made up of PMMA. Write down, rigid lenses are also made up of PMMA. Okay. So in the CAM surgeries which are done free of cost, usually we are putting PMMA lenses which are rigid lenses, whereas in paid cases, the preferred material of choice for putting the IOL, these are the foldable lenses. Okay. So in private sector, we are putting foldable glasses. Now these foldable lenses, these foldable lenses, what is the material of foldable lenses? Write down. They can be acrylic. They can be acrylic. If they ask you which is the best material for IOL implantation, which is the best material for IOL implantation, then answer will be acrylic foldable lenses. Acrylic foldable lenses. What are the other options for foldable lenses? They can also be made up of silicon also. Silicon. Or they can also be made up of Collamer. But the best material is acrylic. Acrylic is the best material, right? So this is all about your intraocular lenses. Now coming back to next topic, you have done the cataract surgery in the patient. What can be the complications of cataract surgery? Complications of cataract surgery. The most common complication, it is called as posterior capsular opacification. Posterior capsular opacification, also called as after cataract. Also called as after cataract. Now suppose you have operated the patient and next day you saw the vision also. Vision was 6/6. Patient was happy and you are also happy, right? But after 6 months, suppose patient comes to you, that patient is having difficulty in vision. The vision, you check the vision also, and vision is not 6/6. Suppose it is 6/18 or 6/24. And you examine the patient on the slit lamp. then what will happen if the posterior capsular opacification or after cataract can be there? Now, what is posterior capsular opacification? See the images and you go back to the anatomy. As I told you in the anatomy of the lens, there was equator, right? Where was the location of equator? This was your biconvex lens, and the point where anterior capsule, and your posterior capsule joins, this point was your equator, right? I told you that equator contains E cells, right? E for E cells, E for equator, right? So why there is opacification after 6 months or 3 months? These E cells, they undergo dysplasia. In some patients, these E cells at the equator, because they are capable of mitosis, in some patients, these E cells can undergo dysplasia, right? And from the equator, these dysplastic cells can migrate from the equator towards the posterior capsule. This is posterior capsule, right? So these dysplastic cells can migrate from the equator towards your posterior capsule, and they can lead to opacification. Of the posterior capsule in front of the posterior capsule, right? So this is how the opacification looks like. Can you see this is an optic? We have implanted IOL. This is optic and this is haptic. Can you see these bubbles, these opacification? This is called as after cataract. Now that we have diagnosed that the patient has developed after cataract or PCO, posterior capsular opacification, then what will be the next step? What will be the management? Does this patient need another surgery? No. What we will do a laser of the patient, right? We will perform a laser, and the name of the laser is ND-YAG laser. ND-YAG laser. With the help of this laser, we will fire some shots in the center of this lens, and we will clear these opacified area with the help of laser, and the center of this lens is cleared. When the center of the lens is cleared with the help of laser, the patient will again regain the vision, right? Patient will again regain the vision. This PCO is clear, the concept of PCO. Why PCO is developing? Because of E cells at the equator, which undergo mitosis. These mitotic cells undergo dysplasia, and the dysplastic cells at the equator, they move from the equator towards your in front of posterior capsule, right? And these cells are called as Elsnick pearls. These are called as Elsnick pearls, opacified area. How you will clear these opacification? With the help of ND-YAG laser, we will make an opening in front of the PC and we will clear these opacified areas. Understood? Now coming back to the theory part again. Write down. Opacified area, PCO, is also called as after cataract. Important question, write down. This is the most common complication. This is the most common complication of cataract surgery, occurring after 4 to 12 months after surgery. So it occurs 4 to 12 months after surgery, right? It is of two types. PCO is of two types. Number one is called as Elsnick pearls, and second type of opacification is called as ring of Somering. So double ring. So these are the names of the opacification. Okay. Now what is the treatment? Treatment also we have discussed. Treatment is ND-YAG laser, capsulotomy. So we will, with the help of laser, so someone has asked me why the opacification only in the posterior capsule? Why not in the anterior capsule? I hope this is the question. So if you look, I told you in the surgery that anterior capsule we have already cut from the front. So that process was anterior capsulotomy, right? So from the equator, these dysplastic cell, if they migrate also, the vision in the center cannot be hampered because it is cut. Anterior capsule is already cut during the surgery, whereas PC was not touched, right? So these opacified dysplastic cell will hamper the vision in PC only and not the anterior capsule, because in front, anterior capsule is already cut. We have done the anterior capsulotomy. Clear? Yes or no? Yes. So this is all about your opacified capsules, complication of cataract surgery. Next important complication, write down. Second, which we have discussed, if by chance your posterior capsule gets ruptured, that is called as posterior capsular rupture. Posterior capsular rupture. What can happen? During the cataract surgery, when you are removing the lens, and during the surgery only, you have not removed the lens yet, and the PC has ruptured, then what can happen? The lens nucleus can fall in vitreous cavity. Lens can fall in the vitreous cavity. Then what will happen? You will shift the patient to the vitreoretinal surgeon. And what will vitreoretinal surgeon do? Vitreous cavity. That process is called as vitrectomy. He will cut some vitreous. That is called as vitrectomy. Plus, he will remove the fallen nucleus. So removal, and then you implant anterior chamber intraocular lens or posterior chamber intraocular lens in sulcus. Means either you implant number 1 or you implant number 2. Either you implant the IOL in number 1 position or in number 2 location. Right? Third complication, write down, most dreadful complication in ophthalmology, which is a very severe infection in the eye, and the name is endophthalmitis. Endophthalmitis. Again, itis means inflammation, right? Itis means inflammation. So write down definition is, it is inflammation of all layers of eyeball. All layers of eyeball except sclera. So inflammation of all the layers of eyeball except sclera is called as endophthalmitis. Question which is asked is, write down question number 1. Most common cause of endophthalmitis in acute post-operative. Most common cause in acute post-operative if the patient present to you with this infection after surgery. If the patient present to you with within 7 days after surgery, then you coin the term as acute post-operative endophthalmitis. And the most common cause is very, very important, staph aureus. Sorry, not staph aureus. Staph epidermidis. Epidermidis is the most common cause of acute post-operative endophthalmitis. Now, question number 2, write down. If they ask you most common cause in late onset post-operative endophthalmitis, late means present with infection after 6 weeks after cataract surgery, then you coin the term as late onset post-operative endophthalmitis. And the causative agent is very, very important. It is Propionibacterium acnes. Short form is P. acnes. Question has been asked many number of times on this one. Propionibacterium acnes. So this is the cause of late onset post-operative endophthalmitis. Very, very prognosis is also very poor. Right, this endophthalmitis. First symptoms: patient present with severe pain, redness will be there, and there will be sudden painful loss of vision. LOV means loss of vision. So sudden painful loss of vision will be there. Patient will have hypopion. Hypopion was pus in the anterior chamber. Patient will have amaurotic cat eye reflex. What is amaurotic cat eye reflex? This is leukocoria, white pupillary reflex. Leukocoria, white pupillary reflex. This is a hallmark sign. The normal red glow of the eye will be absent and patient will have white pupillary reflex. White pupillary reflex. Clear? Now coming back to treatment. When patient comes to your OPD after the operation with endophthalmitis, be it acute or chronic or late onset, right? If the patient is already blind, when you coin the term as patient is blind, if there is no visual perception, means you ask the patient whether the torchlight is present or not. Whether the patient is able to see the torchlight or not. If the patient is not able to perceive the torchlight, then you coin the term as that patient is having no perception of light rays, right? So that patient is called as blind. So if patient after infection comes to you and he is already blind, then what treatment you will do? If patient is blind, you will go for evisceration. The name of the operation is evisceration. And what we do in evisceration, there is removal of whole eyeball. It is removal of whole eyeball. Which layer will be spared? Except sclera. Because in endophthalmitis, there is inflammation of all the layers of eyeball except sclera. So there is no point of removing sclera. So removal of whole eyeball is done except sclera. Second probability, if the patient is not blind, if some vision is present, then what will you do? Antibiotics. You will give intravitreal antibiotics, plus you will go for pars plana vitrectomy. You have to cut the infected vitreous also. And the drug of choice for intravitreal antibiotics is vancomycin plus ceftazidime. The drug of choice is vancomycin and ceftazidime. Okay. So someone has asked if at 2 weeks, then what organism, then patient will not gain vision. So this infection can occur even after 9 months of the cataract surgery. So if patient is having infection after 9 months of cataract surgery, then it is late onset endophthalmitis, right? Vision is depends on the severity of the inflammation, right? Patient can get some good vision also, but usually the prognosis is poor when the patient presents. If already the patient is blind, then you have to remove that eyeball. You have to eviscerate that eyeball. And if some vision is present, then we give direct intravitreal injections. We discussed yesterday also. I told you that penetration point of the needle is anterior to ora serrata. If we are giving injections directly into the vitreous cavity, right? If we evisceration, then what to do with these patients? What to do with these patients? See, we have already removed the eyeball and we can implant artificial eyeball for the cosmetic reasons. But you have to remove, if patient is blind, then you have to eviscerate the eyeball and you implant some artificial eyeball. It is vitrectomy. Cutting of vitreous is called vitrectomy. Because infection is very severe. So vitreous is also infected. So you have to cut some vitreous also. No, eye transplant means you only transplant cornea, right? You are not transplanting whole of the eyeball, right? So because of infection, you have to remove that whole eyeball. Unless if you don't remove the whole eyeball, infection will transmit to the brain via optic nerve, right? So to prevent the infection from transmitting from the eyeball to the brain, you have to eviscerate the eyeball. Only one eye. You have to remove only the one eye which is infected, not the. Why will you remove both eyes if one eye is only infected, right? There's no point of removing both eyes, huh? If only one eye you have operated and there's infection in one eye, why will you remove the other eye? There's no point of doing that. So the drug of choice is vancomycin plus ceftazidime, and it is a very dreadful kind of infection. Clear? So this is all about your cataract surgeries and your management. So we have discussed acquired cataracts, senile cataracts, metabolic cataracts, and cataract because of trauma. Now, next type of cataract is, write down, congenital cataract. Last topic, congenital cataract. Last topic in cataract, congenital cataract. So as the name suggests, congenital cataract means this is present at birth, right? This is present at birth. It is broadly divided into two categories. Write down the classification. Primary congenital cataract, primary congenital cataract, also called as infantile cataract. And the second type of congenital cataract is called as developmental cataract. Developmental cataract. So in primary congenital cataract, the age of presentation of child is less than 1 year. Whereas in developmental, it is more than 1 year. It is more than 1 year. This primary congenital cataract causes severe loss of vision, whereas developmental cataract causes minimum loss of vision. Minimum loss of vision. Now, coming back to types of primary congenital cataract, example is lamellar cataract, also called as zonular cataract, whereas developmental cataract types write down it is blue dot cataract. Blue punctate cataract. Punctate cataract. Important question here, write down. This blue dot cataract is associated with Down syndrome. It is associated with Down syndrome. Blue dot cataract is associated with Down syndrome. Another important thing which we have discussed yesterday, which was associated with Down syndrome, was in anatomy. Which another pathology we discussed, which were associated with Down syndrome? Macrocornea, right? Okay, good. Can you tell me what was the drug of choice for acanthamoeba keratitis? The short form of that drug was? Drug of choice for acanthamoeba keratitis. I told you acanthamoeba is very painful, right? Because it was infiltrating the corneal nerves, right? So yes, drug of choice was PHMB, polyhexamethylene biguanides. And it is quite phonetically similar to PMMA, right? So don't get confused. What is PMMA? PMMA is the material of which ACIOL and rigid IOLs are made up of. Important question, polymethylene methacrylate, right? So PMMA and PHMB. PHMB is drug of choice for acanthamoeba keratitis. Okay, so blue dot cataract is associated with Down syndrome. Now write down causes of primary congenital cataract. First cause, write down. It is congenital rubella. Congenital rubella. It can be autosomal dominant. AD is autosomal dominant. And third cause, vitamin D deficiency. Vitamin D deficiency. Developmental cataract causes, write down. It is posterior polar cataract is the example of developmental cataract. Question which is asked is on the appearance of posterior polar cataract. Write down the appearance of posterior polar cataract. It gives you onion ring appearance. Onion ring appearance. Important question. Next important question, write down. If in the it is primary or whether it is developmental. They have just mentioned congenital cataract. Now, if they ask you most common congenital cataract, overall, then answer is blue dot cataract. AD means autosomal dominant. Autosomal dominant is AD, and most common congenital cataract overall next important image I'll show you. Can you see this picture? So this patient has undergone cataract surgery and we have implanted an artificial IOL. Can you see the position of this IOL? Is it centered or is it dislocated? Can you see this edge is there and it is going superior-temporally? This edge. This IOL is going superior-temporally. It is not centered. This is dislocated, right? Can you appreciate this picture is clear? Give me a thumbs up if it is clear. Yes, this is dislocated, right? So this dislocation of lens, the term is called as ectopia lentis. Ectopia lentis. Lentis for lens. Ectopia means the location is outside. It is dislocated IOL. The term is called as ectopia lentis. What is the site of this location? Superior temporal. So this picture can be asked in your exam, right? And you have to identify that this is superior temporal dislocation, very commonly seen in Marfan's syndrome. Marfan's syndrome. So write down. Next topic is ectopia lentis. Ectopia lentis. So write down the definition. It is displacement of lens from its normal position. Now, what is important is the causes of ectopia lentis. What are the causes of ectopia lentis? First and the most common cause is your blunt trauma. Most common cause of ectopia lentis is blunt trauma, right? Because of blunt trauma, your IOL can get dislocated. Yes, there is treatment for cataract surgery and the surgery, congenital cataract, the treatment is surgery only. There is no medical treatment for cataract. The details of the surgeries are not important for your exam point of view in congenital surgeries. But yes, treatment is surgery for congenital cataract. Okay. So most common cause for ectopia lentis is trauma. Second important cause is senile cataract. So why hypermature senile cataract? Because in hypermature senile cataract, the zonules are weak. And zonules are keeping the biconvex lens in its normal anatomical position. So that is why the lens can get dislocated in hypermature senile cataract. That is why this lens can get dislocated because zonules are weak in hypermature senile cataract. Clear? Third important cause, write down. It can be familial. Autosomal dominant inheritance. Autosomal dominant inheritance. Next important cause, write down. Marfan syndrome, which we have discussed right now. Marfan syndrome will give you which direction of ectopia lentis. This direction you have to remember. You will see superior temporal dislocation. Superior temporal dislocation of the IOL is seen in Marfan syndrome. Talking about next syndrome, homocystinuria. Ectopia lentis is also seen in homocystinuria. And the direction of ectopia lentis is infero-nasal. Direction of ectopia lentis is infero-nasal in homocystinuria. Clear? Inferior, not inferior, it is infero-nasal. In Marfan's, it is supero-temporal, and in homocystinuria, it is infero-nasal. So this is all about your lens. We'll start off for the next chapter after 10 minutes. We'll take a 10 minutes break and then we'll start again. Okay.